Daniele, maybe you can also get my name right on my label. If somebody's able to correct it.
So please close your microphones and we are going to start soon. Hello everyone, thank you so much for being here. We are in the session 3 of the African Climate Resilient and Sustainable Health System and Facilities. Today we are going to discuss vulnerability and capacity assessment for health facilities and communities. Just to remind you, we have simultaneous interpretation in French and in Portuguese. You just need to click in the globe in your toolbar and select the language that you prefer. The course objectives are analyze climate-related health risks and be able to conduct VNA assessment for health systems and facilities using WHO and national frameworks, develop and implement climate adaptation and resilient strategies for health facilities that address infrastructure and maintenance, workforce capacity, service continuity, and emergency preparedness, design and justify low carbon, resource efficient healthcare interventions, include sustainable energy, water procurement, and waste management systems, integrate and apply climate resilience principles into health system planning and policy, align with national adaptation plans and health sector strategies, and communicate and advocate for climate-related health risks and evidence-based solutions to policymakers, communities, and cross-sector stakeholders using clear and targeted strategies. We have 12 sessions in this course, 11 sessions throughout the next 11 weeks. We are in session 3, and the last session will be on November 12, 1 month after the session 11, where some of you can be invited to participate and present a case study here. So this course will offer certificate for those who attend 8 or more sessions live at Zoom, and also passing the final exam with a score higher than 70%. Your attendance is automatically recorded during the live Zoom sessions, and your individual attendance is only counted if you join using your personal Zoom link. Your attendance is not counted if you join with your colleague's link, and YouTube view is not counted as attendance. There will be a final exam. It will have 25 multiple choice or true or false questions, and the link for the final exam will be shared in the final day of the course, and will be closed in the next Sunday. This course, this session will have 90 minutes. We have 2 lectures, 2 presentations today, and at the end we have a discussion. And if you have any questions, please include in the Q&A box. The session will be recorded and will be posted in YouTube in 48 hours. If you haven't the chance yet, please join our WhatsApp group. The link will be also in the chat. I'll give you some seconds to scan the QR code. And today's session's objectives are apply the core concept of climate hazard, exposure, vulnerability, adaptive capacity, and risk within health facilities and community context, explain the concept of climate stress testing for health systems and facilities as it related to preparing for future climate change impacts, develop integrated risks and solution matrix, linking facility and community vulnerabilities to practical adaptation and resilience building actions, and use vulnerability and capacity assessment outputs to inform health system adaptation planning, strengthen cross-sector collaboration, and improve preparedness for climate shocks at both facility and community levels. Today we have these two amazing presenters, Professor Genito Maure, Assistant Professor at Faculty of Science at Eduardo Mondlane University, and Professor Bob Mesh, Executive and Divisional Head, Department of Family and Emergency Medicine at Stellenbosch University. I will start with Professor Genito Maure, who holds a PhD in Environmental and Geographical Science from the University of Cape Town in South Africa. He's the researcher and assistant professor at Eduardo Mondlane University in Mozambique, specializing in climate adaptation. Among his portfolio of climate initiative, he has significantly advanced public health resilience by supporting Mozambique's baseline vulnerability and adaptation assessment and facility pilots before leading the nation's health national adaptation plan. He's also an active member of the WHO Attach and contributor to early warning for AI initiative in Mozambique. Thank you so much, Genito. I will share for you your presentation, and you can let me know when I can advance.
Yes, I can see it. Can I start?
Sure. Can you see? Yeah.
Yes.
Okay.
Can you go to the cover page, please?
Sure. Sorry.
So, thank you very much. Bonjour, boa tarde, good afternoon, or good day to everyone. I'm Genito Maure from Mozambique. I've been tasked with this huge responsibility of driving this session, session 3. So we are somehow going to spend the next 35 minutes on one of the most practically useful skills in climate resilient health systems work, the VCA, the Vulnerability and Capacity Assessment. So as was presented by Daniele in our earlier sessions, we look at the broader relationship between climate change and health and so on. So what we're going to be doing today is somehow practical. By the end of this session, you should be able to conduct or at least commission a VCA for a health facility and also translate the findings into what we would call prioritized action. We will move through 5 areas. Why this is important, why VCA is important. We'll talk a bit about the core concepts you need to understand and the steps of the VCA methodology, including the stress testing and risk scoring, and how to turn these findings into plan. One principle we have to have before we start is that VCA is not about finding everything that is wrong. It's more of finding what. It's also more of finding what already works, and the capacities, the informal networks that exist, the people who hold things together, and so on. So next slide, please. Danielle, can you? Okay. So this is somehow widely known. The health facilities in Africa face what would call a double burden from climate change. On one side, more patients arrive, as you can see on this diagram we attempted to draw. More patients arrive, floods displace people, heat waves cause dehydration and cardiovascular events, droughts affect nutrition and waterborne diseases. I'm focusing on droughts now just because of the announced mega El Nino event, which has a drastic effect in precipitation in certain regions of Africa. So I thought this would be very important to mention. On the other side, the facility itself is already under stress. We have power cuts, we have road flooding, we have water shortages, staff who cannot reach work because the ways, the pathways are already closed. So this is not a future problem. It is happening now in most of our countries, let's say Mozambique, Malawi, Zimbabwe, Madagascar, and so on, and across the whole region are already managing this kind of pressures simultaneously. So a VCA will tell us exactly where the facility sits in this squeeze. What is already fragile? It will also tell us what is holding and what can be reinforced before the next shock arrives. So this is why VCA is not optional for climate resilience health system and health planning. It is a diagnostic step that makes everything else evidence-based. So throughout this session, we will try to follow a district health facility that face three recurring challenges. One is seasonal flooding of access roads. The other one is extreme heat events exceeding, let's say, 38 degrees Celsius, and intermittent power and water cuts. So this facility is considered to be characteristics, not only name, but also everyone else here in this participating in this presentation will recognize it.
Genito, Genito, I think
Before we can go any further, I don't know if
Genito,
the slide is changed.
I think your internet is a little bit unstable. Maybe you can turn off
Can you
your
hear me?
video. Can you hear me? Let's wait a little bit. We have some technical issues here. Genito? I think we lost him. Let's wait a little bit. I think he will reconnect. If he don't reconnect, maybe we can. Okay, Genito.
Can you hear me
Hi.
now?
Hi.
Allow
Maybe you
me,
can.
sorry, I'm
Maybe
talking about intermittent power cuts, and I'm having the same problem here. So
maybe
if
you
you
can
allow
turn
me,
off
I will turn
your
off
camera. Yeah.
okay.
Thank you
Thank
so
you.
much.
Thank you. So thank you for your patience. So as I was saying, we need four core terms before we can go any further. They have precise meanings, and sometimes conflating them leads to wrong interventions. So we should start by defining hazard. The hazard is the climate event by itself. So when we say hazard, we are talking about the flood, the heat wave, the cyclone. It is something that is external to the facility. You cannot change it. So hazard is the climate event itself. When we say exposure, is whether your facility or community are in the path of that hazard. So a facility on a floodplain is exposed. So exposure is partly a physical geography question, is where we are located. So vulnerability, in turn, is the internal conditions that will determine how badly affected you will be when the hazard hits. So a facility with no backup generator, for example, is vulnerable to power outages, like just happened to myself. Vulnerability is about internal fragility, how fragile we are. And it is where most intervention opportunities lie. On the other hand, risk is the combination, which means the probability that harm will occur shaped by the hazard, exposure, and vulnerability together. On the other hand, adaptive capacity is what we would call a buffer. That's why you see that negative sign on under adaptive capacity. Adaptive capacity is the buffer. Strong community health worker networks, for example, emergency protocols, stored supplies, referral agreements, those kind of buffers reduce risk even when hazard and exposure remain the same. On the relationship between vulnerability and capacity, for example, we would bring this example of a facility that has significant vulnerabilities in one domain, such as infrastructure, for example, while having strong capacities in other, such as community trust. So the VCA that we are going to apply should be able to capture all these aspects. Next slide, please. So we would say that risk is determined by readiness. I'd like you to hold this slide in mind for the rest of the sessions. So we could be comparing two facilities, same flood, but completely different outcomes. On the left-hand side, you see facility A has no flood response plan. So medications are stored at floor level, a single road access route, and no community early warning system. When the flood arrives, in this case, services will collapse within hours or minutes. Sometimes we have a case in Mozambique where we have a health unit which is in a very bad situation whenever it comes to flooding. And the cold chain, in this case, will fail. But for the case of facility B, if you see the diagram on the right-hand side, bottom right, you see has a documented flood protocol, medications elevated, an early warning agreement with the village chief, for example, pre-positioned supplies, and staff on standby. When the same flood arrives, with the same hazard arrives, services will continue to work with some disruption, and there is no cold chain loss. So the hazard in this case did not change, neither for case A or B. What changed was the readiness. How ready are we to face this hazard? So the readiness is built through assessment and planning. Our district facility is closer to facility A than facility B in most of African countries. The road floods for 2 or 3 days each rainy season. There is no written protocol. Staff rely on informal phone calls to warn each other. And one more distinction is that the facility is not just about the building. We are talking here about we're not talking about the reinforced concrete structure with no generator or no emergency protocol and no trained staff, because this is still fragile. Resilience is still is a full system. Next slide, please. So a health facility is a node of a larger ecosystem, as I was saying. So in climate stress is able to snap any link in the web that you see here, and each failure will trigger another failure and probably the collapse of all this system that you see there. A facility will depend on multiple interlocking systems. We're talking about referral networks, the community health workers, the workforce commuting from elsewhere, the road infrastructure. Is important how the road infrastructure leading to that facility is, the water supply, the continuity of an energy supply, the communication, and all supply chains. What does flooding do to that ecosystem? For example, for the case of roads, the road will close and will block staff from reaching the jobs. We have the ambulances and power trucks that cannot reach whatever destination. Water systems, for example, will also fail, and wash protocols will break down. Power cuts will cause the cold chain to fail, and equipment will stop working. Each failure will trigger the next. So what we'll be doing, the VCA must look beyond the facility fence. We should be able to try to identify which links are most fragile, which do you control, which do you influence, and which do you have no control over but must plan around. An important distinction here is the service availability is not the same as service accessibility. A facility can be open and staffed, but for example, for the case that we just gave, for the case of the road that is flooded and the community cannot reach it, health services are functionally unavailable. That means accessibility is the operational measure. In our district facilities, the one that we're going to use in this example, there is no backup water supply. The facility depends entirely on the municipal system, which loses pressure during floods. The nearest referral hospital is, for example, 45 kilometers away on the same road that floods. And the supply chain runs on a monthly schedule with no emergency stock protocol. Next slide, please. So we're going to go to the methodology of the VCA per se. So the 5 questions that guide every VCA. So the VCA is structured around 5 sequential questions. They somehow form a practical diagnostic framework applicable at any scale. What climate, for the question 1, for example, what climate hazards matter for this facility? Which events at what frequency and severity over what time frame? The other question would be who and what is exposed? Which people, services, infrastructure, networks are in the path of those hazards? The other question is, the third one, why are they vulnerable? What internal conditions they have that make them susceptible to harm? The fourth question is, what capacities already exist? What is working? What can be built on? The fifth question would be, what actions are needed? What do we do? In what order? In what sequence? What are the resources that we have? And what are the resources that we don't have? So should maybe notice that question 4 is more about capacities, not just weaknesses. This is where most of the assessments that we know fail. They produce a long list of problems and miss to identify the strengths that already exist. So we will try to dive a bit deeper into those 5 questions in the next few minutes. So let us start with the first one on the hazard. Next slide, please. So the first step is to identify which hazards are relevant for the specific facility or community. Let us not assume. We should not assume. We have to have evidence. So, for example, we should look at these 5 hazard categories. These are just an indicative list, but if we have different hazards, we should also include them. So let's see. Do we have floods, including flash and riverine flooding? Do we have extreme heat? Do we have drought affecting water and food security? Do we have storms and cyclones? Um, uh, uh, um, and is the disease ecology changing in time? Are there any shifting outbreak patterns that we are noticing? So hazard identification should cover also the time frames, what has happened in the past. So we need to look at the local memory and historical records. These are of high value, invaluable. These are of high value. What is happening now in terms of current trends? And most importantly, is what climate projections are telling us for the next 10 to 20 years, because we should not plan based only on historical and current observations, because climate is changing. So we should also look at the projections, because the projections will somehow shift the dynamics of the not only of the hazard but also of the risk. For example, Southern Africa, the climate signal is clear. We have increased frequency and intensity of cyclone-associated rainfall, more persistent drought flood alternation, and a warming trend that is already visible and pushing heat stress above what we would consider safe threshold for outdoor workers and also patients. So our district facilities experience flooding four or and six rainy seasons. So heat events have above the threshold that we mentioned before, 38 degrees. It now is occurring on average 12 days per year, up to up from I think it was a decade ago. Malaria transmission is shifting seasonally and geographically. So we should remember identifying a hazard is not the same as assessing the risk. We must also ask whether the facility is exposed to this hazard or and whether it is vulnerable. Only then we can have the risk picture. Next slide. So this slide is about who and what is exposed. So once we know the hazard, we ask what is in the path. Exposure assessment covers four main categories. So we talk about people, infrastructure, lifelines, and networks. So I think this slide is self-explanatory. People can be the patients, staff, and vulnerable community members, the infrastructure, you name it. There's a long list of infrastructure depending on the setting of the facility. The energy grids, water sanitation systems, and roads are part of the lifeline, and the networks. We can mention here the referral pathway, supply chains, the community health system, which links are physically or operationally exposure. So mapping exposure can be done using simple tools. We can use satellite imagery, community sketch maps, facility walkthrough audits, and so on. A critical distinction to state we need to state explicitly is that exposure now we differentiated exposure from hazard from risk. Now we are differentiating exposure is not the same as vulnerability. A facility can be highly exposed right on the floodplain and still have low vulnerability if it's well prepared. And a facility with very low exposure can be highly vulnerable if the system is fragile. So we need to assess both separately. Next slide. So we should look at the vulnerability since the vulnerability is the hardest concept to pin down because it's not visible from the outside, differently from hazard and so and the other exposure and so on. Vulnerability requires that we dig into the internal condition of the facility. We need to look at how the infrastructure is built, how old it is, what is the condition, is there any flood protection, is there any storage above flood level and so on. So we also need to look at wash components, the water source security, the resilience of the sanitation system, generator availability, the fuel stocks, and so on. The solar capacity, I would say renewables, yes, not only in solar, but we should look at operations. How um, uh, is there any lack of emergency protocols, poor supply stockpiling? Do we have single staff coverage for critical roles? The human capital, is the staff trained? Is there any turnover? The mental health of the staff itself, which seems to be somehow neglected, and the ability to reach the facility during emergencies. So each domain has diagnosis questions. The checklist in the toolkits that are available makes this systematic. In our case, the district facility scores poorly on wash and energy, definitely, because of the description that we gave. We have no backup generator, no water storage tanks, depends on municipal supply and so on. So it would score better on human capital, experienced staff with long tenure, and strong community relationships. Next slide. Next slide. So do? How do we assess vulnerability systematically? So the answer is somehow structured in the so-called diagnostic checklist. So the checklist has several components. What I'm presenting here is like a grouping. I'm sorry, it's not well. It's overlapped. So we need to look at the healthcare facility across those domains. Here I'm presenting a group of domains. The WHO checklist as 6. Um, grouped here, infrastructure and wash. So we're trying to assess, is the facility above the one in a 10-year flood line, for example? Are sanitation system functional after flooding? Is water storage available for at least 72 hours? If we go to power and communications, we should look, is there a backup generator? Is it tested regularly? Is there a communication protocol when power fails? If we go to the supply services and supply chain, are essential medicines stocked for at least 4 weeks? Is there a temperature monitoring log for the cold chain? Is there a supplier of last resort agreement? This checklist should not be looked at as pass or fail kind of checklist. They generate a scored profile that shows where the facility is strong and where the facility needs investment. So for the case of the WHO attached to, and it provides some internationally validated versions of this checklist. It has been adapted from a for lower resource settings as ours. So we will try to return to these at least for the links where they're available in the final slides. Next slide, please. Okay. So we also need to assess, I think this is one of the most important, as I said, because this is one of the most skipped step when we do VCA. When we focus on vulnerabilities, we will produce plans that are demoralizing somehow, unaffordable sometimes when it comes to investing in infrastructure, and disconnected from local reality of financial constraints and other constraints. So if we also map capacities, we find the building blocks that make resilience plans somehow achievable. So we should look at these key capacity indicators. The first one is, are there tested emergency plans, even if partially, or if we have formal plans that have been activated in past events and worked, those plans are a capacity. Right? The capacity, the community health workers are there in most of our countries, are often the first and last line of defense. They know the community, they are trusted, and they will fill the gaps for the formal system cannot. The informal early warning systems. We do have the village shifts, the church networks, the radio listeners, channels that alert communities before formal systems do. Those exist on the ground. This is a capacity. This is a capacity which could be strengthened. Do we have partial backup systems? A small power a solar panel, for example, a 200-liter water tank, a fuel reserve. These are capacities, even if incomplete. Do we have referral agreements, documented or understood agreements with other district hospitals and NGOs or private providers? So our district facility has key strength, the one that we're using as an example. We have a head nurse that has 15 years of experience who has managed every past emergency. It has an active village health committee that meets monthly. And third, it an informal but reliable referral agreement with the district hospital. So vulnerability does not mean absence of capacity. Those coexist. The VCA should capture both and produce a balanced picture. Next slide. So here is how do we gather this evidence. So VCA would work best when it triangulates three types of information. It should be able to capture quantitative data. We're talking about records, climate records, facility utilization data, infrastructure age and condition scores, supply stock levels. This gives numbers and trends. We should look at facility audits where we have structured walkthrough using standardized checklists. This will give us the observed conditions, not reported conditions. We should look at quantitative insights, focus groups with staff, interviews with community members, participatory exercises. This gives us context and local knowledge that numbers could not capture. So this triangulation will mean that checking one source against another. If the audit says the generator is functional, but staff says it has not been tested in 2 years, that contradiction is important. The VCA should be able to resolve it. In practice, many VCAs in the region, in our African region, are done with limited resources, as I said, a small team, a few days on site. Mixed methods should, mixed methods do not require large research budget. It requires disciplined observation and a honest conversation. Next slide, please. So here is an important aspect that needs to be also considered. So quantitative data tells you what is happening, but communities know why. Local knowledge is able to close the gaps in formal data, especially in settings where observation networks are sparse. It's very common that in our African settings, we do not have like observation stations in every place where we have a healthcare unit, but the community know how what is happening and why. In many of our African settings, the districts, the community health workers are able to map flood-prone paths. They know because that's their daily path to work. They are able to identify which household lose water supply first. They are also describe how power outages historically have clustered around specific seasonal events. None of these seems to appear in our national data set. We are not able to capture this. If we triangulate across sources, this will give our VCA credibility. When a community focus group identify the same risk as your facility walk through at the district climate record, you have what we would call robust evidence. Where they disagree, then tension should itself is informative. It points to data gaps or differences and lived experiences that are worth investigating. So participatory methods should, be implemented where we do community mapping, transect walks, seasonal calendars. These are not soft science. They are structured, rigorous, and often reveal systemic vulnerabilities that the instruments cannot detect. Yeah, move next slide, please. So there is an important, once the hazards, exposure, and capacities have been mapped, we need to rank what to act on first. The risk matrix, this is widely known. The risk matrix formalizes that judgment by plotting likelihood on the vertical axis, and the consequences on the horizontal axis. So likelihood is how probable is this event, while consequences, if it happens, how bad is it going to be? How bad is the impact going to be on health service delivery? In our district facility, a 3-day flood, for example, is moderately likely in the wet season and carries severe consequence because it cuts off the road access, contaminates the water supply, and knocks out the generator inlet. That combination places it in the top right quadrant where you have the dark red color, which means high priority. An extreme heat event above 40 degrees is less frequent, but still has what we would consider high consequence for cold chain medicines and laboring patients. So it also scores high. What we see in the metrics here is are just scores. The metrics will not take decisions for us. It will structure the conversation within among the facility manager, the district health officials, and community leaders about where investment and contingency planning are most urgent. So scores should be revisited annually as climate projection facilities capacity continue to change. Next slide. Daniela, how am I doing with the time?
You can have more 10 minutes.
Okay, so yeah, I believe I will use less than that. Okay, so another important aspect is how does the health system perform under conditions far more than severe? Because we've been mentioning things that we have observed, but we also have the climate projections that are telling us that, okay, there is a possibility of a changing climate that we have now. So that means we are going to experience climate that we have never experienced before. So the lived experience and the recordings do not have this information. So this is called testing the system boundaries. So it's the climate stress testing. So at what point does the system stop functioning? So the climate stress test, this is the question of the climate stress test. Now, we're not asking whether a facility can handle a flood. We ask how large a flood is needed before the facility can no longer provide safe maternal care. That threshold, the critical boundary, is what we are trying to locate. So let us try to walk through our district example in terms of figures, in terms of numbers. We have a diesel generator with 200 liters capacity. This will come on the examples just for you to think about it. So we have a normal consumption of 8 liters per hour for lighting, for refrigeration and medical equipment. During a grid outage, the facility only has 25 hours. Yeah, it's 200 divided by 8, 25 hours of autonomous operation. If road flooding prevents fuel resupply for 36 hours, that means, which is quite realistic for a 3-day flood scenario, the facility will cross its critical threshold at hour 25. After that point, the cold chain will fail, the theater lights will go out, and suction equipment is lost. Running these kind of arithmetics before the disaster happened, let's planners choose. Should we increase the tank capacity? Should we pre-position a backup fuel cache? Should we negotiate a priority supply agreement or even accept the risk and build a patient diversion protocol? Each option has its own cost and residual risk. So stress testing makes those explicit rather than leaving them as unexamined assumptions. The same logic applies to water shortage. So staff to patient ratios under evacuation conditions or medicine stock levels during a supply chain disruption. So we should pick the resource, define the consumption rate, define the resupply window, and calculate the gap. Next slide. So this is what we consider time to critical failure. Time to critical failure is if we define it, is a precise diagnostic concept. It is the interval between the onset of an hazard event and the moment the facility can no longer deliver its minimum safe service package. This interval is our window of action, the time that is available for early warning, resource mobilization, contingency activation before harm becomes inevitable. For the case of our facility, the district facility, the combined stress calculation should run like this. So the flood cuts road access at hour 0. The generator will run up to hour 25. The municipal water supply, etc., which depends on water and electricity pump, depends on electric pump, fails at hour 6 when the backup system is exhausted. So we go on again by hour 25, power is gone. So the minimum safe service packet, normal delivery, and so on should becomes undeliverable between 18 and 20 hour 18 and 26, depending on which service we are looking at. This 18 to 25 hour window is the active action window. Otherwise, we won't be able to act. Next slide. So we also have this domino effect of climate hazards. So health facility risks rarely arrive alone. A single climate event is able to trigger a cascade of events. For example, we can have flooding, which will cut road access, which will delay fuel resupply, which will cause power failure, which disables the cold chain, which renders vaccines unusable, which forces patient diversion to already stressed referral hospital. Each link in that chain is a separate system failure, but all are caused by the same initiating hazard. So understanding this cascade logic changes how we prioritize the resilience investments. So hardening the generator inlet against flood water, for example, which is a relatively low-cost physical measure, is able to break the chain at step 2 and prevent every downstream failure. If we focus only on the cold chain freeze, by contrast, this will address the symptoms rather than the causes. So in our VCA, we always ask, if this hazard occurs, what does it disable first? We should look at the first to be disabled, the first element to be disabled. And what does that disablement then trigger? What does it mean for the rest of the chain? So if we are able to draw this cascade explicitly, even as a simple flow on the paper with the community, is one of the most powerful analytical steps that we can take on our assessment. Next slide, please. So a VCA is only as valuable as the actions it's able to generate. So what we are trying to show on this slide is that it marks the pivot from analysis to planning. Every priority risk that has been identified in the matrix that we showed earlier should map to at least one adaptation measure, something the facility, the district, or the community can actually do. So adaptation measures will fall into a useful typology. Some will fall under structural measures that change the environment. For example, a raised generator platform, elevated fuel stores, rainwater harvesting tanks, shaded waiting areas, and so on. We have procedural measures that change what people do. Standby rosters, prepositioned supply caches, patient diversion protocols, early warning checklists, capacity building measures, and so on. So in the risk to solution mapping exercise, so participants often discover that many high priority risks have low cost procedural solutions that require, for example, simple documentation or agreement and practice, not essentially new budget lines. Next slide, please. So here, when the risk matrix is pointing to multiple things that need fixing, the question becomes, where do we start? So we have multiple aspects that have ranked with more or less the same number of points or scores, the same score. Where do we start? So the recommendation is to begin with what we call low regret or no regret actions. So these are measures that deliver clear benefits regardless of how the climate evolves. So, for example, writing an emergency plan costs almost nothing. Staff training will strengthen routine care as well as crisis response. Reviewing, for example, the stockpile protocols takes an afternoon. You do not need a climate projection to justify them. We should start by this. Once the quick wins are in motion, you should be able to evaluate larger investments against the four criteria. Let's say risk reduction. We'll ask, for example, whether the measure addresses one or of the most critical failure points in our cascade analysis that we referred to recently. This is not a peripheral inconvenience, but we need to look at it as a node whose failure brings down multiple services. The urgency and feasibility will ask whether this can be implemented quickly with resources that we actually have or can access. A technical superior solution that is years away from funding is not a priority action today. We cannot do that. It requires a lot of time planning. Equity will ask whether the measure reaches the most vulnerable, the communities that are furthest from the facility, those who need the fewest alternatives, the staff groups with the least support. And robustness will ask whether the intervention will hold across a range of scenarios and remain maintainable across once the initial project closes. So what we see, the visual on this slide captures the weighting logic, urgency, costs, equity feed, and all in one. Next, I think this is getting close to the end. So again, resilience is not a destination where you reach once and then halt. So considering that climate hazards are changing, they're shifting, facility capacities changes, and staff turnover and the aging of equipment and community vulnerability, which evolves with socioeconomic conditions, also are involved in this equation of resilience. A VCA conducted today will need to be revisited every, let's say, 3 to 5 years. Sooner, if there is a major climate event that affects a given facility or facility service delivery model. So in terms of adaptation cycle, we should look at these nodes as a continuous cycle, which needs to be done recurrently. So assess, plan, implement, monitor, review, and redo this cycle. So each step of each completed cycle will be able to generate evidence that will be needed to improve the next cycle. Also is a need of institutionalization. Institutionalizing this cycle is crucial for the VCA to turn VCA a routine part of the annual facility planning, not an occasional donor-funded kind of exercise. Next. Finally, I'd like to close with 5 things that I think are important to be carried forward from this session. Is that first one is that risk is not just about the hazard, it's the product of exposure, vulnerability, and capacity together. Changing one of those will change the risk level. Second, the VCA is not a damage inventory, is a structured inquiry that should identify the capacities, what is at stake, why it is at stake, and what can be done about it. Third, the local knowledge. I'm including this local knowledge here because it's important when it comes to the limits and so on. The local knowledge is not supplementary. We need to triangulate this knowledge with formal data sets and so on. The cascade thinking prevents that single points gives a false sense of security. Always we should ask what the next domino piece is. So lastly, the VCA is not finished when the matrix is complete. It's finished when the adaptation actions are documented, resourced, assigned, and scheduled for review. Everything before that is analysis. And thank you for your attention in this session. I hope I be able to provide you with expected input for the upcoming part of this session. Thank you very much.
Sorry. Thank you so much, Genito. It was an amazing presentation, very clear, a lot of examples. I'm sure that our participants are already thinking that they can do and apply some of your examples. And then I'm going to call our next speakers who will guide us into the checklist, and then you will see how you are going to do this VCA analysis. Our next speaker is Professor Bob Mesh. Professor Mesh is current president of the World Organization of Family Doctors in the Africa region and a professor of family medicine and primary care at the Stellenbosch University, South Africa. He also coordinates the primary care and family medicine institutional network in sub-Saharan Africa and is the editor-in-chief of the African Journal of Primary Healthcare and Family Medicine. He has interest in climate change and primary healthcare in the Africa region and has collaborated in this with Climate Action Accelerator and Climate Change, Migration, and Health Network. The work has focused on how to improve climate resilience of primary care facilities, continuing professional, educational, and development of primary care providers, as well as pre-service education. He also collaborates with the School for Climate Studies at Stellenbosch University and has a focus on building educational and research capacity on climate change and primary healthcare. Thank you so much, Professor Bob. It's over to you.
Okay, thank you. Just before I start, I just want to check what your plans are in terms of questions. I see we've got, about 30 minutes left.
We can go 10 more minutes after. Okay, if you are available.
All right, so I'll try and go a little bit faster over the initial material because I think it's similar to what Genito has done. So I'll just start by also acknowledging my collaborators, the Climate Action Accelerator and the Western Cape Government in South Africa, and of course the funder, FLIR. So by way of introduction, so you know, I'm a family doctor, basically. And so I'm approaching this from somebody who works in the health system, a clinician. This is the WHO measurement framework for health systems from a primary healthcare lens. And it's just interesting to note that now, for the first time, and I've put it in red there, that resilient health facilities and services is on the map of what should be measured when you're looking at primary healthcare. And so, yes, so we now need to find ways of actually doing it. This is a definition which I think Genito has sort of covered in other words, but climate resilient healthcare facilities are those that are capable to anticipate, respond to, cope with, recover from, and adapt to climate-related shocks and stress, so as to bring ongoing and sustained healthcare to the target populations despite an unstable climate. And this diagram from the World Health Organization kind of in a sense, illustrates that definition. And it's similar to what Genito was saying about, Clinic A and Clinic B earlier on. On this graph on the left side, it's basically saying, where do you start? Are you a Clinic A or a Clinic B in terms of your baseline capacity? Then you experience a climate shock, such as a flood or a stressor, such as a drought. You respond and you may recover. And it's a question of when. How do you recover? Do you collapse, as many health facilities are? I know in Mozambique there has been many facilities that have collapsed. Do you recover back to your pre-event state, or maybe your learning is so good that you actually become even more resilient going forward? And I think one of the problems, of course, that we're experiencing in Southern Africa particularly is that the shocks and the stresses often come again before you've fully had a chance to recover. So the WHO have produced this guidance on resilient health systems, but this is very much at the health system level. So this would be, I think, very helpful if you're at a national or subnational level, you're a policymaker, somebody in charge of a health system. But this is the guidance that, is very helpful if you are on the ground at a facility level, or in a sub-district with a few primary care facilities or a district hospital, and you're thinking about how do I actually approach this topic of resilience? And they have essentially highlighted these 4 areas of the health workforce: water sanitation, hygiene and waste, energy, and then infrastructure and technologies, equipment and products, as the 4 key areas that they think should be looked at. What's interesting in this framework is that you see on the left-hand side, they've actually linked it to climate change. So in terms of these shocks and stressors, these are the 4 areas that one needs to think about in terms of building resilience. But also on the right-hand side, it's the same 4 areas that you need to think about if you're thinking about preventing harm from healthcare and environmental sustainability. So they've actually linked together climate resilience and environmental sustainability around these 4 topics. Also, like Genito, I very much see this as a sort of connecting your sort of top-down and bottom-up approaches. If you have a sort of health-related national adaptation plan, obviously this can help guide managers and release resources and look at, broadly speaking, at what needs to be done. But without, I think, this local level, this more granular assessment, because sub-districts and districts, of course, across countries are all different, it's difficult to really come up with an action plan that will work in that specific context or location. So we need sort of both of these, and they need to connect in the middle. This is just another diagram, I think, also of what Genito has gone through quite in depth, so I'm not going to spend time on this, but again, showing the link between hazards, exposure, risks, solutions, and the moderating effects of vulnerabilities and capacities, which, of course, what we try to measure in the BCA. So let me come, this is, I think, the real heart of this thing, to share with you some practical steps if you were, in doing a facility level BCA. So we embarked on this in South Africa, in the Western Cape, and we held hands with the Climate Action Accelerator, because they had produced this manual on how to go about it. And you can actually, the latest version, it's always sort of, the iterations are always improving, you can get from the website. But when we came to this, they had previously piloted it in a hospital in Chad, quite a difficult situation, and we were now going to pilot it in primary care facilities in a rural part of South Africa. So as a result, really, of our experience of doing this, we're now conceptualizing this process actually as having eight steps. So it's not really a tool, more of a process. And I will speak very quickly about each of them. But firstly, it's preparing for the VCA. Secondly, reviewing the existing data. Thirdly, adapting and contextualizing the tools. Fourthly, collecting some quantitative data in an audit. Then fifthly, collecting some qualitative data through focus group discussions, putting it all together in a risk and solutions matrix. In a participatory process, then prioritizing the solutions, developing an action plan, and then finally, in step 8, supporting the implementation of that action plan as you go forward. So step 1 in preparing for the VCA, we did it as a research project, and I think one of the things that we're interested in, we're experimenting now with in South Africa, is whether this can be done by a sub-district management team or a facility management team. But what I'm going to speak about really, I suppose, is seeing it more as a research activity at this point. So we had a team that consisted of an emergency medicine specialist, a family physician, a planetary health researcher, some consultants from CAA, and the sub-district manager, as well as public health specialists from the university. So it was quite a diverse team of people. It's important to define the scope of the VCA. Is it going to be one facility? Is it going to be the whole sub-district? Is it going to be a sample of facilities in that sub-district? Is it going to also include the district hospital? So those were important decisions. And then also in terms of the objectives, is it going to just focus on climate resilience, or is it also going to think about issues related to environmental sustainability? In our case, in our sub-district, the district managers said they actually wanted a carbon footprint as well as doing the VCA. And obviously then engaging with local stakeholders, particularly the Department of Health in that district, and we also connected with some of the community members in the District Health Forum. Oh, I haven't got this bar in my way. Let me go up here. So then step 2 was to find out what do we already know actually about this sub-district. The sub-district that we looked at had 6 primary care facilities in it. So we wanted to find out what information is there about the climate hazards, the future climate, and what do we already know about the vulnerabilities and capacities, the morbidity and mortality in this district. And so some of that can already start to be populated into the risk and solution matrix. And then what are the knowledge gaps that need to be still addressed in the VCA? So this was just some of the information that we gathered. There was some quantitative information. As you can see, the chart at the top was a prediction from our Department of Environmental Planning in South Africa about the increase in temperature and decrease in rainfall in this particular part of the country. And a little map on the left there showing you where it is on the west coast of South Africa, and the 6 primary care facilities that we visited. And then some sort of more qualitative information down the bottom. We found that flooding in the area had actually cut off twice in a row the main town, which is the left-hand photograph. So the road had been washed away by the river. And one of the villages, or one of the clinics was up in the mountains, had pretty much half the village had already been destroyed by a wildfire. So we were gathered some information on some of the climate hazards and risks and events that had already taken place. So stage 3, we discovered this was particularly important because obviously we were taking something that had been previously used in a hospital in Chad and now taking it into a very different context. So we had to go back, actually went back to the WHO guidance. The WHO guidance in that document has over 200, I think, suggested items that could be audited, and often in a language that is not very accessible to healthcare workers. So we went back to that, though, and took out from that what was relevant, combined it with what was in the existing audit 2, and came up with 72 items that we thought were relevant to our context. And we think that this sort of validation of the tool is probably necessary wherever you're going to use it, depending on the scope of the facilities that you've selected. Also, of course, to understand some of the other tools and have training on them, the interview guide, how to use the matrix, how to conduct the focus group discussions, and so on. So the training and the adaptation was very important at this stage. Then we went to visit the 6 primary care facilities, very similar to what Genito was saying. We had our audit tool, our 72 items. We then sat down essentially with the operational manager, who was a nurse of these clinics. We went in a sort of more of a discussion interview. We went through the tool and completed it for each facility, and then walked around and observed and inspected the facility, took photographs of key things to verify and sort of eyeball really the reality. So the audit tool, just to tell you sort of the structure. So on the right here are the 4 areas that the WHO recommended for health facilities. And then on the left is the health system stuff. And we didn't take very much of this, but we took the service delivery component and we added it in to the 4 that the WHO had recommended. So we ended up with an audit tool with 6 areas that we audited, looking at energy, water, waste and sanitation, infrastructure and equipment, the workforce, emergency preparedness, and other aspects of service delivery, such as whether health programs had sort of anticipated some of the challenges and whether there was any approach to the environmental determinants of health in the community. So this is just to show you, eyeball you what the tool looked like. So it's very much just going through categorical data, but the column on the right actually was very important to make qualitative notes on what was said and to qualify some of the answers with sort of more richer information. So it's just a screenshot of one of the audit pages after it had been completed. So you can see, yes, we had the categorical answers, but there was a lot of qualitative information that was really valuable to also write down for each facility. We then took those audit tools and put them into an Excel spreadsheet. So one column for each of the facilities with all of the answers from the audit tool. And then in this yellow highlighted area, we then summarized for the sub-district the results of the audit according to the 72 items. So that gave us a final sort of picture audit of the whole sub-district. So then stage 5 was we went back a few weeks later to 3 of the facilities, the larger ones and the ones that seemed to be a little bit more at risk. And we conducted focus group, we call them focus group tabletop discussions. So we literally met around a table, usually with a group of 8 to 10 people. Some were from the facility itself, so nurses, nurse in charge, receptionists, pharmacists, and so on. And some were from the community-based services, so community health workers and the nurses that coordinated things in the community. So it was usually a combined group. And they sort of started by drawing a map of the facility and the community, placing themselves in it, and then remembering a scenario. And they all chose actually extreme heat. So although the pictures I showed you earlier were of flooding and wildfires, the main problem that they experienced, especially in the summer, was extreme heat up into the 40s. And then they sort of remembered that day, that week, and how they dealt with it and what happened to the patients, what happened to them. And through that discussion, we would explore the vulnerabilities, the capacities, and the potential solutions that had come out of their experiential learning or that they could see would be valuable in the future. So we had a very sort of rapid approach to data collection and analysis. So while one person was facilitating this discussion with the group, another person was standing in the room with a very simple template where they were collecting information already on what came up from the group around vulnerabilities, capacities, and solutions. The conversation was also recorded, so we could listen to it again later. And then after the group, this person then immediately wrote an analysis, a very deductive approach, sort of what did they say about vulnerabilities, what did they say about capacities, what did they say about potential solutions for now or in the future. So, and you can see on the right here, this is the type of 2-3 page summary for each focus group that was created. And then from that, you could extract across all the focus groups vulnerabilities, capacities, and solutions that relate to the same six areas as the audit. So then stage 6 actually was to integrate all of this into a risk and solution matrix, which was again for us in an Excel spreadsheet. So this is just the screenshot. So you can see the first column was the climate hazards and also sometimes sustainability challenges. The second column was vulnerabilities, then capabilities, then the resultant risks, then the potential interventions. Interventions might have come from the people that we had interviewed and talked to, but they could also come from outside experts or people with technical information. And then they were classified according to the 6 areas that I've outlined to you. So we came up with an integrated matrix taking information from step 1, step 3, step 4, and step 5. So then the final phase was to go back actually to the sub-district management team and to now present to them these solutions, the risks and solutions according to these 6 areas. And then to discuss with them, one area at a time, what had come up as potential actions or solutions. And then the kind of criteria that were used was, what would the cost be to the health system? What would be the impact on climate resilience or the carbon footprint or other environmental harms? What actions actually might belong to other sectors? So there's a need for intersectoral collaboration here. So stuff about roads, for example, obviously the health department is not going to solve that. Whether it was aligned with existing policy and therefore more likely to get support, and of course the feasibility of doing it. And as a result of that, we took, I think there were 40 or 50 potential solutions. We ended up with this streamlined action plan for the sub-district. So there were some actions that were short-term that could be done essentially with existing resources. There were some actions that could be done longer-term that needed additional resources. I'm not going to go, I think, through all of this, but very, very practical actions that could be taken. Let me just show you a few. So in terms of infrastructure, they were looking at insulation in the roof spaces and painting the roofs with highly reflective white paint to reduce temperature, have better temperature control. In terms of products, actually, there was a need to provide the community health workers actually with protective clothing to continue working in floods or extreme heat and quite adverse conditions. With waste, for example, at regional hospitals, the province had already introduced an alternative medical waste system that used heat and friction to take hazardous waste and turn it into very harmless pellets without therefore needing to incinerate medical waste. And we were looking at whether the sub-district could actually adopt that same system to deal with their waste, which would of course now be an example of improving environmental sustainability. So after all of this is great, we had an action plan. Of course, there was then a need to support the district management team in implementing it. And this is what we're still really busy with, I think. The results were presented, of course, to the district level management and to the province. In fact, actually also informed policy making at the provincial level and the development of an action plan for the province to follow up with the local leadership. So the short-term things which should be easy to do still can fall off the agenda if there's not an ongoing conversation. And these things need to be embedded into the annual planning cycle and budget of the district if they're going to happen. Right, so final thoughts. I haven't got my eye on the time. I hope we're doing all right. But just to say that this was very much an adaptive learning process, not a sort of one-off kind of assessment event. It was very participatory. It wasn't just a lot of outsiders coming and sort of measuring and assessing people. There was value, I think, in having both national and local facility level VCAs. The actions varied from small scale, very easily done, to larger scale ones. And I think this interdependence of looking at both climate resilience and environmental sustainability was helpful. And then the need to embed this within the annual planning and governance processes and not just leave it at the level of an action plan. I think that is it. So I hope the time hasn't gone completely away from us.
Amazing, amazing. Thank you so much. That was really, really interesting. A lot of example, and I really want that the participants take a look very carefully in your slides and see the checklist and also the manual. I will share with them also the link with these guideline. And Genito, please turn on your camera, and we have 10 minutes for our final discussion. I think we can address many of the participants' doubts here. Great. So I have some very interesting questions here. I have one that maybe can be discussed by both of you. In an area exposed to multiple hazards, is that a way to grade them in order to focus on the priority ones, especially when the resources is scarce? Who wants to go first?
So Prof. Bob, to go first, or want me to go?
No, go for it.
Yeah. There is, I would say that there is an approach which is called multi-hazard risk assessment, which allows you to, of course, those hazards will not occur. One will be a consequence, it's likely to be a consequence of the other. So what we see in most cases that we have, for example, I will just bring an example of a central region in Mozambique called Beira City, which was hardly hit by Cyclone Idai. Because it's a coastal city, what you have is that you have flooding that is caused by the direct precipitation, but also flooding that is caused by the flood, by the river. It's a fluvial flood. And because tropical cyclones normally raise the tides, so you have these three types of events. But the hazard here is not the rain that is falling, is the flood inundation. So depending on the cause of the flood, you may say, okay, this flood is the magnitude X, and we have to prepare for that flood. So we should look at the potential impact, the magnitude of the impact rather than the magnitude of a hazard per se, because depending on how prepared you are, you can have maybe elevated structure. I mean, it's not a problem. Yeah, you have to look at the potential of risk, and then
well, just a couple of thoughts. The one is that from a service delivery point of view, you can't have like an emergency preparedness that's different for every possible emergency. So it's very important actually that we have emergency preparedness for, like an infectious disease outbreak or a multiple casualty event or a climate hazard, and that somehow these need to be integrated. But I think the issue is that sort of emergency preparedness has not until now really considered climate hazards. So it needs to be kind of added in. In terms of multiple climate hazards, we did have, for example, in the Cederberg, which I was showing you, we had multiple climate hazards. We had, the main one was heat, but we also had periodic flooding and wildfires. And in fact, even one facility was at risk from sea level rise. So we had to consider them all. It wouldn't have made sense to have just considered the one. So they were all in the matrix.
There is also a very interesting question, and I think this is like a next step that maybe people are not there yet, but it's good to start to thinking about is what indicators and tools would you recommend for measuring the resilience of a health facilities and a health systems to climate-related shocks, while maintaining the quality and equitable access to, and he used reproductive, maternal, and newborn health service. I think both of you can also respond to that, like indicators of resilience. I think we are in this step now, considering that we are going to have the global goal on adaptation, and there will be some measure on that. But
Well, I would just refer the participants to my last slide, which I did not show, but has a very good material on the WHO guidance, which I think the checklists themselves are somehow a very good guidance on that regard. Of course, some of the indicators will depend will be specific to the locations where this exercise is going to be conducted. But overall, I would recommend that the guidance, the existing guidance, either from ATACH and WHO or both WHO and ATACH is used, the one that has been referred by Prof. Bob as well. Yeah, I would go for that one.
Yeah, my reflection on that one, I mean, clearly it's a sort of complex adaptive process. There's not going to be one indicator that's going to like nail it, you know. And the intention, of course, is to come up with a viable action plan that can actually improve resilience, having looked at this complexity. I suppose, you know, you could, for example, take those 6 areas that I mentioned and pull out 1 or 2 indicators for each and come up with some sort of score. You know, that might be possible, but that wasn't really, in our case, the intention of the process. The intention was to sort of look at it comprehensively and the complexity, and come up with an action plan. That was really the focus. Yeah.
Just maybe a small addition to that is that for the exercise that was conducted here in Mozambique on the vulnerability adaptation, we have explored the exposure, the vulnerability adaptive capacities, and also the elements of the existing capacities. So a focus should be given to what we would consider low-hanging fruits, what we call no regrets or low regret, because of course we are all constrained in terms of financial resources, but we should always look at things that we can do and can always give like a positive result in the given conditions. But overall, adaptation is only reached when an action that is changing, I mean, our vulnerability is taking place until we can reduce this to the maximum possible.
I think one of the things we need to learn in the health sector is how do we get our hands on some of the money that is available for adaptation, which we're not very good at actually getting our hands on. And maybe you're, I see you've got down the road, you've got something on financing. Maybe that will help us to find the financing for some of these actions. Yeah.
Yeah, and you both talk about prioritization and see what impact will cause the highest risk, and then go through this first and then address the other. I have another question regarding to community participation for Genito. Within the health system you present, communities are included as part of the system. However, in reality, communities are considered as recipients, not as the integral part of the health system. This requires a change in attitude and a practical tool package for integrating communities in the health system within the model you presented. Do you have such example? I think in climate change, more than ever, we need to include the community, and I think you show that. Maybe you can give us more example.
Yeah, in fact, I was I mentioned a different initiative that I was working on. It's called Early Warning for All. The Early Warning for All is a very important component, which is communicating to the last mile. But the communication to the last mile is not only about the way I convey a given message. It's also a way that message is perceived. And the measurement of how that measure is perceived, or the assessment to that, is, do people react positively to the message that I conveyed? That definitely cannot be done if I don't involve the communities. So the reaction, the positive reaction of the community is a way of assessing the message that is trying to be. So the concepts of co-produce these kind of processes. Let's discuss with the communities, because they are the ones, as I shown in one of my slides. We are not only assessing, I mean, all these registries of events and the climate data and so on. We are also assessing what is their local community knowledge. So we have examples of sitting with the community, asking them, for example, what happened in the years X to Y, when where we don't have records of a given event. They will tell us, oh, we have marked on the wall, this tree was underwater because of the floods that happened when this kid was born. These kind of things. So it happens somehow to look at the age of the person and try to identify extreme events that have occurred for them. So that applies also to health. In health, we also need to understand what kind of disease outbreaks we had, and when, in places where we don't have observations. There is no way to do it without involving those communities that live there, especially the elderlies of these places. Yeah, this is one of the examples that I can give.
So
Prof.
two
Bobby,
quick
I think
thoughts.
from
The one is that, of course, this process is focused on the climate resilience of the health facility, but one can also have a very similar process on the climate resilience of communities. And of course, the two can be related, where the health system is one of the capacities that a community might have. And we have actually experimented a little bit with working in a participatory way with communities in a very similar process, but now with community members. We've published a little bit about it. Mandisa Tenego from Botswana in the African Journal that was mentioned earlier has described her process for working with communities. And then the second thought is that, from the health sector point of view, especially in South Africa, we're trying to implement what we're calling community-orientated primary care, where we sort of try and think about the community as a whole and not just the patients in the consulting rooms. But getting to that, I don't know who asked the question, but getting to that point of really engaging and participating with communities seems to be very hard for health systems. But we are on a road, I think, to try and do that, and then through that to try and also address some of the environmental determinants of health. So can a COPC approach at the local level, tackle some of the environmental determinants outside of the households?
Thank you so much. Professor Mesh, there is another question here, very interesting for you. Once a facility has completed the VCA and identified its priority risks, what is usually the biggest challenge in turning those findings into actual changes at facility level? You mentioned that you are in this phase now, and maybe you can give some examples. They are examples, they are not necessarily will happen in all the situations, but maybe you can bring some solutions.
I wish I could share with you like amazing success stories,
Yeah.
but it is difficult. For example, in this particular sub-district, the sub-district manager that we work with has just left. So there's always this kind of sort of unforeseen circumstances that make implementation difficult. We tried to get some external funding for some of those activities. We haven't succeeded yet with a couple of funders. We've had traction, as I say, with the province, and I think they're about to launch their provincial action plan, which this research has influenced, and that may release resources and support some of the actions that are in that action plan. But it's difficult, and I don't think we should underestimate the implementation aspect of the action plan. Needs a lot of thought. We're also, as I say, experimenting now in the Eastern Cape with a actual sub-district management team doing this for themselves, supported from a distance by researchers. And that may, well, we'll see how it goes, but may end up with greater ownership of the action plan by the sub-district management team. Maybe that will help. We're also piloting the same process in districts in Kenya and Ghana and Malawi, and we'll report back in due course. Yeah.
Amazing. Okay, we will be here. Well, if you have any materials that you want to share with the participants, please send to me, and I think they will be very happy. And I will end this session. And before I end, I would like to challenge the participants to conduct a VCA in your facility as an exercise. Choose, pick a hazard and try to go through the steps. And this will be part of our last session, and you can present. So we will prepare a registration form if you want to participate on that, and we will select some participants to present this in our final lesson. And we will have a panel, and you can take doubts. Maybe Professor Mesh and Genito can participate in the panel. We will see if you are available. But thank you so much. It was a very interesting session and very informative. I think everybody benefit a lot with that. Thank you.
One little ride on what you've just said. We've also had medical students, as part of their undergraduate training, perform aspects of the VCA in their primary care facilities. There's something also that you could think about. Quite an interesting exercise. Yeah, thanks.
Thank you so much. Thank you, Genito. Bye-bye,
Bye-bye.
everyone.